Yeah, so MET's become a very common target right now. And a couple of things going forward. One is defining MET overexpression, which has actually always been a challenge because we have IHC, we have NGS, and then we have FISH testing. So what you call as MET positivity has always been very difficult to do. There's a panoply, for lack of a better term, of MET ADCs now. There's one, ABV400. There are several of these coming down the pike right now that have shown some evidence activity. Where they end up is going to be tough to see, and how you use MET expression to target it. There are some that we believe that you need very little MET expression, kind of mimicking the story from trastuzumab deruxtecan, where we now give it to HER2 1+ in breast cancer, as well as any tumor if it's 3+ expressed. So thinking about it that way, but there's a few coming down the pike, as well as there's more EGFR-MET bispecifics now as well, all in clinical studies. So we talked about Amivantamab as a EGFR-MET naked antibody, but now there's some antibody drug conjugates targeting this as well. So there's a lot going on in the MET world. It's challenging because if you look at just exon 14 skipping, we have 2 approved drugs, Capmatinib and Tepotinib. Very good drugs, hard to supplant those right now, and it's also a very rare population, so it's hard to do studies. I think the bigger population is going to be in patients who overexpress MET. Where do you do those cutoffs? Do you need to do testing as well? And interestingly, some of these compounds are actually now being tested across tumor types. Gastric cancer, where we know there's evidence of MET, colorectal cancer, head and neck cancer as well. So we'll have to see where the data takes us, but MET's kind of had a resurgence with these ADCs as well.